Okay, good morning. I was already introduced. I just wanted to add that I am from the Dominican Republic, so you will have to adjust your accent capabilities to adjust to my Spanish accent. EngenderHealth has worked with for a long time to support our in-country partners to improve the services they provide. We started many years ago improving the female sterilization services and informed choice capability of our programs. And along with that, we also did a lot of improvement of the places where these services were provided. But as the time passed, we, in addition to improving female sterilization through training and counseling and TA to the services, we started to develop other tools to improve quality improvement. EngenderHealth has a suite of tools that aim to contribute to the improvement of the facilities at their own. COP, that as was already mentioned, that stands for client-oriented, provider-efficient, was developed in the late 80s and the 90s in a pilot program in Kenya and Nigeria, and is one of the approaches of our suite of quality improvement. We have whole site training, quality measuring tool, community COP, design walkthrough, enrich, and ensuring clinical quality. All these approaches are being used in one moment or the other to improve the quality of the services we provide. How COP improves quality? We have developed COP also based on the theories advanced by Deming that were just mentioned by Pierre. And we are use some of the documents and thinking of Bruce and Jane or Carlos Hueso and Judith that develop the client's rights and providers' needs. The COP is a package. It includes the handbook. It includes self-assessment guides. The self-assessment guides are self-administered guides that help staff to look systematically and consciously to the issues related to the service they provide. So they are not going to assess their own performance, but the performance of the service as a whole of the group. We have also the client interview guides, and these are very important because they encourage staff to talk and to listen to their clients and to hear from there how they think about quality, what quality means for them. And we have the client follow analysis that measure how long the clients have to wait for get services and how long the contact with the provider lasts. The focus is on processes and on doing things right, the right way the first time. So how COP improve quality? The self-assessment guides are based on simplified statements of evidence-based practices, guidelines of best practices. So the COP process is at the same time an assessment, but is educational. It reinforces standards, and staff and supervisors through the process increase their awareness related to a lot of issues. And in the process of doing that, they will find that sometimes they don't have standards to provide services, that they need to develop those standards. And also, they learn to, oh my God, I have the tendency to speak too much. And they have the tendency to not think about what is important. So how we do this COP is both a process and a set of tools designed to improve health services. We start with the first COP exercise. An important part of the first COP exercise is that we ask staff to define quality. What quality means for them. It's not the quality as we, the external facilitators think about it, is their quality. We help them to analyze to identify the gaps and then to analyze the process. We develop the action plan. We put together the COP committee, and we start to implement the solutions. One point I need to do is that when we are developing the action plan, it's important to really analyze the root causes of the problems they face and to dig down to see what is really the problem, because sometimes we may say, oh, we don't have supplies because they are not being bought, but we need to know why is that a problem. And the process is then repeated the next 3 or 4 months. And in the meantime, the committee will follow up on the implementation of the activities. And if needed, we recommend that there is a second or later exercise where we are going to see what the process is going, and we need to apply again COP or other tools. Oops. So the COP philosophy is that it needs to be participatory. And the organizational development theory and the participatory action research suggests that individual and team identification of their problems lead to more effective actions. It's very different from one external advisor will come. So all the COP tools are participatory, inclusive, simplified to engage all the members of the facility. And COP improve quality by giving the power of change to the facility staff and by giving guidelines on how they may work together to improve rather than telling them what they need to do. And staff then start changing, and there is a personal and organizational commitment to change. Our logic model is that we have the processes that I have already mentioned, defining quality, engaging everyone, that will have some outputs related to that. Service quality, staff morale will be increased. The outcome will be that the sites would meet basic service standards like cleanliness, less waiting times, and clients will be more satisfied with the services. At the end, the impact will be that it will be an increased use of the health services, and that the health income will improve. And the result can be very simple, from needed of supplies for quality improvement, or just to have to put some benches for the clients to sit down. Other illustrative changes are more clinical related, if you want, and here you can see that there are human resources issues that are attended to, and we need to implement and add other kind of approaches like training, in clinical in-service training, and that we do a lot also to improve record keeping and analysis of the data also. Strengths are that introduce the quality concept. The tools are help the providers to solve their own problems, the problems by themselves, and that helps to start and improve the communication among clients and among staff, and help communicate standards. And finally, before we are asked to close, the limitations are that it requires a lot of time, it requires facilitation, flexibility, and time. It requires local commitment, institutional commitment, and COP alone is not the answer. It should be complemented by other quality improvement activities. And as we know, change takes time, and the COP change will take time also. Comparing the change from baseline when we use COP to change over time is one approach that we will be using to evaluate the impact of COP. Thank you.